This tutorial is designed to provide culturally competent, trauma-informed guidance on working with the children of parents with co-occurring mental health and substance use disorders. Children growing up in homes led by parents with these co-occurring disorders face a multitude of challenges and are at risk for a host of psychosocial complications. Unfortunately, while their parents access treatment services within multiple systems, the children are often either overlooked or receive only ancillary attention. This course will provide participants with a clear understanding of the risks associated with being the child of a parent with co-occurring substance use and mental illness, a developmental lens through which participants can understand how growing up in such an environment might affect and challenge typical growth and development, and clinical suggestions of trauma-informed services and practices shown to increase protective factors in families and promote child well-being. A full reference list accompanies this tutorial and can be found and downloaded from the National AIA Resource Center's website. An individual living with co-occurring disorders has received a diagnosis in 2 or more spheres of life, generally pertaining to a substance use disorder and a mental illness. While each disorder has its own specific challenges, when the disorders are co-occurring, their challenges compound one another. This magnifies the difficulties for the entire family across numerous life domains, as well as across the life course of each individual. Millions of Americans have been diagnosed with co-occurring mental illness and substance use disorders. Due to transient living arrangements, lack of health care, long waiting lists, child care and transportation barriers, active addiction, and acute mental health symptomology, the majority of adults affected receive no treatment at all. Those that do enroll in treatment generally receive parallel or sequential treatment, with only a very small percentage receiving services that address both their mental health and substance use needs in an integrated system of care. While no complete verifiable data exist on the number of children impacted by parental co-occurring disorders, we surmise that many millions are affected. Understanding how parental co-occurring disorders affect children is an area of social welfare that needs more research. Limited attention has been paid to the specific circumstances of children whose parents live with both mental illness and substance use. This has resulted in a lack of programming efforts and standards that have been scientifically proven to be effective or promising for these children. This vulnerable population has a very limited level of evidence-based support available to them. Even though these children are exposed to numerous cumulative risks, they are not generally receiving adequate formal services. Very few agencies and organizations specifically target children of parents with co-occurring disorders. Instead, these children access time-limited, disjointed services at a multitude of locations. These vulnerable children belong to an invisible population, seldom noticed and commonly falling through the cracks of multiple service systems. Even when their parents access services from various providers, the child's well-being is rarely assessed. The service systems focusing on the parent are rarely equipped with the human and financial resources to properly address and care for the children involved. Some service providers are solely focused on an individual client and do not inquire about the family composition. Others may lack a thorough understanding of childhood development and, therefore, feel less capable of engaging the child. It is also common for providers to assume that the child's needs are being addressed by other service and support systems and are therefore not critical to address. Some providers and families fail to understand the complex and potentially harmful developmental consequences of growing up in such circumstances. They maintain that children are resilient and, depending on their age, will probably not sense or remember the stress and strain on the family. Only recently have we begun to clearly understand how early childhood experiences manifest throughout the life course in terms of physical and mental health outcomes. Research has consistently documented that the greater the number of risk factors children are exposed to, the more high risk they become for cognitive, behavioral, social, and emotional delays and difficulties. It is well documented that children growing up in homes headed by a parent with co-occurring mental health and substance use disorders are commonly exposed to ongoing stressors that can have a cumulative impact on their behavior and development. In fact, in one 3-year longitudinal study, researchers found that the risk of child behavior problems increased with the number of areas in which the mother reported difficulties. The study indicates that the more difficulties mothers reported in their daily functioning, the more difficulties their children experienced. These kinds of cumulative stressors do not just create difficulties for an individual at one particular time. The impacts of such adverse experiences build upon each other, affecting the individual throughout his or her life. For children who have a parent with co-occurring disorders, there is a much higher likelihood that they will have been exposed to or will have experienced multiple risk factors at a young age, thereby increasing the risk for cognitive, physiological, and developmental delays. Often, the youngest children in the families are the most negatively impacted, as they possess the fewest developed skills for coping and stress management. In addition, children have the most limited cognitive ability to make sense of what is happening, why it is happening, and what to do about it. This cognitive deficit, while developmentally appropriate in young children, adds to the uncertainty and chaos in an already challenging home environment. One of the most renowned and comprehensive set of studies that examines the relationships between early childhood experiences and health outcomes in adulthood is known as the Adverse Childhood Experiences, or ACEs study. It arose from a partnership between the Federal Centers for Disease Control and Prevention and Kaiser Permanente, an integrated managed care consortium. Launched in 1995, this ongoing research collaborative has consistently found that the likelihood for health and social problems in adulthood increases with the number of adverse childhood experiences an individual faces growing up. Specifically, heightened numbers of ACEs are linked to increases in drug use, sexual activity before the age of 15 for girls, sexual activity resulting in pregnancy, depression, post-traumatic stress disorder, PTSD symptomology, and psychotic symptomology. Repeatedly, studies show a strong relationship between adverse childhood experiences and the development of health conditions that are among the leading causes for adult mortality. While healthy debate persists as to the extent of nature versus nurture in the onset of mental illness and substance use disorders, there is consensus that children living in households with a parent with a co-occurring disorder are at risk on both fronts. They may be born with a genetic predisposition for substance use disorders and mental health issues, as well as experience daily exposure to an environment that may breed such disorders. Research has shown that these children are more likely to receive a formal mental health diagnosis than their peers growing up in homes without parental co-occurring disorders. A much larger study compared the outcomes of children of parents with substance use issues, mental health issues, or co-occurring disorders. The rates of substance use and internalizing disorders, such as depression and anxiety, were highest among the children whose parents had a co-occurring disorder. The children also experience a range of feelings when thinking about whether or not they might develop a mental illness later on in life. A child's risk for developing psychosocial complications increases with the number of stressors present in the home. Unfortunately, in families where one or both parents are affected by co-occurring mental health and substance use disorders, multiple difficulties and adversities are commonplace. Adults with mental illness and substance use disorders are far more likely to be living in poverty than their peers without either disorder. Women with co-occurring disorders are particularly at risk for living below the poverty line. Sadly, of all people living in poverty, the vast majority are children. A dense body of literature documents the detrimental effects of growing up in childhood poverty. Childhood poverty is conclusively linked to poor outcomes throughout life. Both the consequences of growing up in poverty and growing up as the child of a parent with co-occurring disorders are far-reaching. The majority of mothers who live with co-occurring disorders have also been victims of physical and sexual violence. Higher rates of domestic violence occur in households with maternal co-occurring disorders than when mothers are not affected this way. Physical and sexual abuse from domestic partners and husbands are more common among women with dual diagnoses than among women who live with only one diagnosis. Traumatic experiences and subsequent symptoms of post-traumatic stress disorder are typical for these children, as well as their mothers. Often, these traumas occur in clusters or cycles, as one kind of trauma creates susceptibility to others. For example, a mother who is severely physically abused might be more likely to become physically abusive with her children as a result of her difficulty managing her symptoms of aggression or irritability caused by PTSD. With devastating implications, some researchers have established that families who report incidences of parental mental illness, substance use, and domestic violence are at a greater risk for a host of negative outcomes, including homelessness, reliance on food banks, child placement in foster care, and others. Unfortunately, the combination of stress, unresolved traumas, and cycles of intergenerational violence leave these families at heightened risk for child maltreatment. However, even for children who do not experience direct victimization, the effects of exposure to such traumatic events have devastating consequences. Specifically, children who witness violence directed at or perpetrated by one of their primary caregivers have significantly poorer outcomes than do children who witness random acts of violence. The former have difficulty regulating their emotions related to the events, experience more feelings and acts of aggression, and experience more PTSD symptoms. For these children who are witnesses to domestic violence between their caretakers, the threat of constant harm and pain can leave the child in a persistent state of hypervigilance, which, over time, has significant deleterious effects on their body and psyche. Children of parents with co-occurring disorders typically experience sporadic and/or extended periods of unstable and unpredictable caretaking. Many of these children are left alone for long periods of time, are inconsistently fed and bathed, and are at an extremely high risk for accidents. These neglectful behaviors can be due to lapses in cognitive functioning and decision-making due to the mental illness, substance use, side effects of the medication used to treat these conditions, or preoccupation with the addiction itself. Parents taking medication to manage and control their mental illness might also be lethargic, overly aggressive, or display other negative side effects. This is particularly true when a parent and doctor are working together to find an appropriate dose of a new psychotropic medication. These circumstances can greatly influence the parent's personality as well as their ability to parent their children. As children are highly egocentric throughout their infancy, toddlerhood, and young school-aged years, they tend to attribute changes in their immediate environments to something they did or did not do. This mode of internalization can result in deep feelings of shame, guilt, and self-blame.
I just wanted for someone to tell me that my mom and dad loved me, and to tell me that it wasn't my fault. I thought it was all my fault.
Changes in parental behavior and affect can be frightening and alarming for children. Depending on the child's age and the availability of other adult figures for support, these parental behaviors can leave lasting developmental marks of varying severity. Often, this type of unpredictable parental behavior related to caretaking results in a child's disorganized attachment with the caregiver. Disorganized attachment can manifest in the child in numerous ways. Some children have difficulty regulating emotions, challenges making social connections, poor academic reasoning, and severe emotional disturbances. Retaining custody of their children, especially during early childhood, is a struggle for many women with co-occurring disorders. In one particular study, fewer than 40% of the mothers with co-occurring disorders interviewed remained their child's primary caregiver throughout the first 10 years of life. This can lead to residential instability for the children, which is nationally defined as living in 2 or more residences in the past 3 months. Notably, many of these low-income families, according to research, move for various reasons that are beyond their control. Some reasons that children are forced to relocate repeatedly include housing eviction and foreclosure, and parental incarceration or institutionalization for psychiatric instability. Children who move frequently experience greater barriers to accessing consistent education, appropriate social services, and primary medical homes. Moreover, not all moves occur as a family unit. Various circumstances collide, leaving some children with family friends, family members, split between multiple interim caretakers, or in the child welfare system, bouncing between different foster families. Depending on the impetus for the move, some families might find themselves with limited time for planning and packing, let alone for discussing the difficulties of the move and family separation with the children. This results in the accumulation of stress, worry, and pain from unpredictable relational and physical changes in the environment, which can be very difficult to counteract without the support of the primary caregiver. Frequent, unpredictable, and/or emotionally disruptive moves for children are linked to high rates of school absenteeism and neighborhood problems, such as low levels of social support and neighborhood violence. Absenteeism that begins with a young child being kept out of school due to a lack of parental involvement can lead to poor grades and poor behavior, which often progresses to further absenteeism and truancy. Disrupted attachments and frequent or unpredictable separation from the parent is linked to failure to thrive in infancy and depression, delinquency, and academic problems throughout young childhood and adolescent development. The inability to maintain regular access to caregivers is further complicated by the fact that, even when present, many of the caregivers have erratic parenting styles and availability. This leaves the children vulnerable to disjointed comprehension and an inability to manage their emotional state, as they lack a consistent adult to help them make meaning of their experiences and feelings. The stigma and isolation that children of parents with co-occurring disorders face are harmful and distressing. There is overwhelming societal pressure to hide a parent's illness. If a child does choose to disclose the parental co-occurring disorder, the revelation is commonly greeted with fear, anxiety, anger, or blame. The parent may even face social and legal consequences or threats, depending on the extent of the mental illness and/or the addiction, how the information is received, and by whom. As a result, adolescents may be unwilling or unable to speak about it, thereby impeding the exchange of social support that they and their family could benefit from.
I wouldn't go to anyone. I wouldn't like an outsider knowing what was going on in our house. It's private business. We wouldn't go to our friends because you'd be scared that they would say it to someone. Family is very personal. I wouldn't trust others.
Parentification occurs when the child, at any age, is expected to take on the role and/or duties of the parent. This often involves caring for the parent or other children in the home to varying degrees. Commonly, parentification begins at a young age, with increasing expectations and responsibilities as the child gains skills and reasoning capacity. Although cultural contexts shape our expectations of the roles that children, adolescents, and adults should play, the shifting or reversal of roles can be further isolating to children who already have burdens and impediments on their development. Having one or more parents with co-occurring disorders often introduces a level of stress, anxiety, and uncertainty that greatly affects the health and well-being of any child. Uncertainty about why the parent is acting the way she is acting and how she will act next produces high levels of stress. These stressors can vary depending on the circumstances, including the income of the family, the mental illness diagnosis, the age and gender of the parent, the presence of other caregivers in the home, the effects of the specific prescription medication needed to manage the illness, and their drug of choice. The various stressors present unique challenges to family functioning and affect ideal childhood development. While isolated events of heightened stress can be a tool to motivate individuals, and occasional stress can boost immune system functioning, chronic exposure to stressors can permanently change the way the brain develops in ways that affect later behavior, psychological experience, and health. People who are exposed to this chronic stress experience lower levels of immune system functioning, resulting in more illnesses, difficulty regulating and managing experiences and emotions, and more. Fetuses, infants, and young children are especially sensitive to this developmental and biological sensitivity to stress.
As a child, I tried desperately never to have a problem because our family had so many. So I became perfectionistic and hid my fears, concerns, and needs from everyone. On the outside, I always appeared strong, self-assured, and able to handle anything. But I developed a lot of shame, felt that I was going crazy too. I always had tremendous anxiety that someday somebody would find out that I was a fraud.
Although research has substantiated specific risk factors and enduring negative consequences for children of parents with co-occurring disorders, very few specialized services have been developed to principally address children's needs. Children typically receive treatment only after problem behaviors have been identified. This treatment tends to be time-limited and targeted to the specific behavior, rarely looking holistically at the needs of the children or addressing the root causes of behaviors or symptom expressions. With the grim reality that children from families affected by co-occurring disorders are at high risk for a host of complications, an intervention at a single point in time is not sufficient to address the needs of the families. Children living in this environment need various supports throughout their childhood. To support children who have parents with co-occurring disorders, the field needs a paradigm shift. An array of comprehensive, family-centered prevention and intervention services that spans the prenatal period through young adulthood is essential to adequately address the unique and complicated needs specific to children of parents with co-occurring disorders. Even with the numerous risk factors that families with co-occurring disorders face, the development or reinforcement of protective factors can still have a positive impact on the individual and the family. The following supports and interventions are attempts to buffer risk factors and increase protective factors to promote the well-being of children and their family unit. Provider awareness of parental co-occurring disorders is the first step in helping a family thrive. Obstetricians, substance use treatment providers, mental health clinicians, social workers, and other professionals can ask simple screening questions during the intake process to determine if their client may have co-occurring disorders and, if so, if there are children in the home who may need services. Agencies do not need to provide these child-specific services on site. Simply being aware of and referring appropriately to community partners links a child to critically important assistance. Supportive services to children affected by parental co-occurring disorders can begin in utero. Chronic stress during pregnancy can result in atypical fetal development and decreased immune support, increasing the child's susceptibility to postnatal illnesses. The fetus of a woman with co-occurring disorders may also be exposed to illegal substances, as well as prescribed psychotropic medications used to alleviate maternal depression and anxiety. Working with a mother to reduce substance use during pregnancy, combined with closely assessing and monitoring any prescription medications she may be taking, is critical to minimizing fetal abnormalities, reducing preterm labor, and increasing infant birth weight, all of which can lead to physically, mentally, and emotionally healthier infants. Pregnant mothers should be screened for illicit and prescribed substance use, as well as alcohol use, at each prenatal appointment. If a mother is found to have either a substance use disorder or a mental illness, she should then be screened for co-occurring disorders. SAMHSA has developed a repository of screening tools that clinicians can use with clients. For more information, visit their website. It is critically important that this screening be conducted in a non-judgmental way, allowing mothers to talk openly and honestly without fear of consequences. Clinicians should have supportive community referrals on hand to help mothers manage their symptoms during pregnancy, including referrals to integrated co-occurring treatment, case management, and public health nurses. Agencies that work predominantly with adults with mental illness, substance use, or co-occurring disorders should integrate screening questions into the intake process to determine if children are present in the home. Staff from these agencies should also have knowledge and contact information for appropriate referrals for the children. A parenting assessment can help determine if additional resources, such as parenting interventions or family therapy, may be warranted. Child Welfare Information Gateway has compiled a list of parenting assessments. For more information, visit their website. Administration of these assessments should be done in a supportive, non-confrontational, non-judgmental way. Parents should be led to believe that being honest and forthright leads to help for them and their families, rather than a guaranteed loss of their parental rights. Otherwise, parents are likely to withhold information or no longer seek out treatment. The postpartum period can be especially challenging for mothers with co-occurring disorders. Hormonal changes that accompany pregnancy, delivery, and lactation may heighten the symptoms of a woman's mental illness and can even bring on new or more severe psychiatric symptoms related to postpartum depression. This, combined with the added stress of parenting a newborn that may be especially fussy or challenging due to prenatal substance exposure, increases the risk that a mother will relapse or increase her substance use, or experience difficulty maintaining her mental health. Substance-exposed infants may have impaired regulatory capacity, resulting in fussier babies, babies that are more difficult to soothe, or babies that have difficulty feeding or sleeping. This can be a tense time in the parent-infant relationship. Due to the stress and strain, difficult-to-soothe babies are at highest risk for child abuse or neglect. In general, the first 2 to 3 months after the birth of a child are known for having the highest rates of infant emergency room visits, as parents desperately want help calming their crying infant, have trouble discerning what the problem is, and aren't entirely sure where to turn. When a newborn is chronically fussy, for whatever reason, emergency room visits are even more common. Many parents with co-occurring disorders, especially those who are using substances, taking psychotropic medications for existing diagnoses, or testing out new medications in response to new psychiatric symptoms, might struggle with learning to read their infant's cues and determining how to respond appropriately. There are many home visiting professionals who can help new parents during this adjustment period. The postpartum period can be an incredibly isolating time for any new parent. Postpartum supports and services are invaluable for ensuring that mothers and fathers have access to the resources and information they need to appropriately care for their new baby as well as themselves. In particular, home visits from public health nurses are among the most helpful postpartum services provided. Nurses provide significant assistance to new mothers with co-occurring disorders who have many health and mental health issues to manage for themselves, while simultaneously learning how to care for a newborn. Supporting a dependent child requires concurrently addressing the needs of the parent. A functional family system and optimal child functioning require that all family members' needs are met. For women with co-occurring disorders, the role of trauma in parenting has to be addressed to adequately support the children in the home. Mothers experiencing mental illness and addiction describe many of the challenges they experience in parenting as directly related to their trauma history. Women with trauma histories are preoccupied with their own safety and display multiple hindrances to effective parenting. Specifically, these women may pay limited attention to the children due to a need to seek out safety from real and anticipated danger, provide limited physical and emotional availability, have significant trust issues, display a diminished capacity to empathize with the child, experience decreased intimacy with the child, have a lack of positive parenting role models, and have little confidence in their ability to parent effectively. In addition to integrated treatment for their mental illness and addiction, mothers with co-occurring disorders can benefit from a multitude of ancillary trauma-informed interventions that will provide trickle-down effects to the children. Often, mothers relate their mental health and substance use disorders directly to their trauma histories and negative attachments with caregivers, which, in turn, influences their own relationships. Mothers receiving treatment for co-occurring disorders often describe feelings of inadequacy, low self-esteem, and doubt in their parenting ability. Many of these women were never nurtured themselves and have no conceptual framework for what a nurturing relationship might look like. Developing a strengths-based connection with the mother that models a positive and nurturing relationship can provide her with an opportunity to feel nurtured herself and recognize the invaluable role she plays in her child's life. Once a woman has the chance to address her own psychosocial needs, she is more able to take an active and positive role in learning effective parenting skills. Many factors influence the quality of attachment between a parent and her child. The mother's mental health, physical health, current substance use, ability to respond to the baby's cues, attachment history, and the personality of the child all affect the relationship's development. Accessible, empirically supported, or evidence-based parent-child intervention can significantly reduce dyadic stress and increase mutual satisfaction, thereby promoting positive attachment, parent-infant co-regulation skills, and a healthy relationship. Strong and secure attachments provide significant buffers against risk factors associated with families headed by one or more parents with co-occurring disorders. For mothers, chemical and hormonal secretions from strong feelings of attachment and mutually satisfying dyadic relationships can help regulate the maternal hormones, further providing an ideal relational setting for optimal infant and child growth and development. Conversely, a lack of healthy attachment is linked to higher rates of abuse and neglect and poor biological, psychological, social, and economic outcomes throughout the child's life course. Research demonstrates that program engagement is high and attrition low for women whose families are included and engaged in their recovery process. Children are often the motivation parents need to seek out treatment. Conversely, parenting responsibilities are commonly listed as a top reason for women refusing treatment for co-occurring disorders, as many programs do not make accommodations for families.
The attitude that recovery must come first and that women need their own space to recover and cannot concentrate on their recovery with children present reflects a lack of understanding of access issues and of the fact that true recovery for a mother usually works only when it includes her children.
Even if a woman recognizes that she needs residential services, she frequently decides against it out of fear of being separated from or losing custody of her children. Families should have access to residential treatment facilities that can accommodate mothers and children. Motherhood can be a normalizing experience for women in treatment and can provide clarity with regard to a woman's identity, role, and purpose. Often, women refer to their children and their role as a parent as their reward and source of hope for the future. This attitude carries with it the belief that change is possible, especially in mutually satisfying parent-child relationships. Raising children can be highly motivating and enjoyable. Parents entering treatment present providers with an unusual opportunity to disrupt intergenerational patterns of substance use, mental health problems, and violence through the delivery of prevention and treatment services to children along with parents. In addition to promoting parent-child attachment and bonding, family-centered residential treatment ensures that the parent receives treatment that addresses her needs within the context of her role as a mother. At the same time, the accompanying child is continually assessed for health-related and developmental milestones. The child is able to receive services on-site, including medical care, therapy, and early intervention/educational services, thereby creating a cohesive medical and social service home. Inpatient facilities often provide unique opportunities for family maintenance, and the staff is able to pay particular attention to the dynamic maternal-child relationship. The retention of the mother-child dyad and the opportunity for the mother to receive intensive parenting intervention in the treatment setting, where it will be practiced, often improves the quality of the caregiving relationship. Many of these families are eligible to receive therapy too, which can both strengthen areas of resilience and rebuild areas of the relationships that have been impacted by trauma or difficulty. Family-friendly outpatient treatment programs can also increase parental engagement and retention. However, mothers commonly miss appointments or treatment sessions due to a lack of childcare or accessible transportation. To address these barriers, outpatient programs can offer childcare, either on-site or through a community partner, while a parent is receiving services, and can offer vouchers for public transportation to engage parents in program participation. In addition, the program should take into account and plan for the client's role as a parent when conducting treatment and discharge planning. These program initiatives should all be conducted with cultural competence and empathy, showing the mother that she can receive beneficial services without judgment or shame. Providing information and support to children at developmentally appropriate levels about mental illnesses and substance use can repair and strengthen the bonds between children and their parents that have been strained over the years. Clinicians can assist parents in understanding the impact of their substance use and mental illness on their family, and provide them with tools they can use to speak with their children about their disorders. At the same time, parents with co-occurring disorders should be advised sensitively and constructively about the effects of their condition on their children. This instruction can promote empathy and understanding between the children and their parents, normalize feelings of anger and strife, and promote overall familial well-being.
Make sure children are informed that this illness is an illness that has a name and that many people have it. It has nothing to do with their actions or their parents' displeasure with them. There are treatments and medication for it, just like a heart problem. Tell them what behaviors they can expect and what to do and say if those behaviors are exhibited. Encourage them to discuss it.
The isolation and stigma that is so common in families affected by co-occurring disorders often leads to constricted social and support networks. Increasing formal and informal supports of both the parents and the children can be an effective way to promote pro-social behaviors and protective, nurturing relationships. Children who grew up in homes with parental co-occurring disorders appear to have limited resources to develop the skills and relationships that help buffer against the risk factors they face. One of the most important protective factors a child can have is a positive and stable relationship with a caring and positive adult. Interventions should assist the child in identifying a personal support group that may consist of a combination of compassionate adults. This group of supportive adults can assist in easing the isolation and stigma the child may feel. The opportunity to talk to someone about personal feelings has been cited by these children as a simple yet effective way to feel more confident and supported. One programmatic tool to promote social and emotional competence in children is to coordinate parent and child services so that children of parents with co-occurring disorders can participate in support groups, ideally while their parents are receiving outpatient services. These support groups will provide a safe space to process the children's experiences growing up in these environments. Young children and adolescents can create social connections, learn self-soothing and relaxation techniques, interpersonal communication skills, pro-social behaviors, and assertiveness training. It is important to be allowed to verbalize feelings in a safe space. Within a facilitated group setting, youth have access to adults who are able to model safe and appropriate expressions of intense emotions. It may also be beneficial to involve the parents in some group sessions. This structured environment can provide a safe place for families to talk about the hard-to-talk-about issues, such as how the parent's substance use and mental illness affects the child. Many women with co-occurring disorders can benefit from the support of other women who have similar diagnoses and have had success navigating the social service system. These peer mentors are effective in establishing relationships with women, providing support and encouragement, and modeling an appropriate supportive relationship. Peer mentor support upon discharge from a program can also assist mothers in linking themselves and their children to services and developing appropriate family-friendly activities. Interventions focused on strengthening the family can be particularly helpful. The common assumption is that children are too young to understand the loss of, or separation from, their primary caregiver, frequent changes in their residence, or overall chaos in the home. However, current research demonstrates this is far from the reality. Children are extremely sensitive to change in their environment and caregiving systems. Beginning in infancy, they are able to sense change, tension, chaos, and stress, even if they don't know how to verbalize what they feel. Family therapy can help participants learn helpful problem-solving and conflict resolution skills, express their needs in a safe and supportive environment, enhance family relationships, break negative patterns and cycles of relating, process difficult events, and address child discipline concerns. Helping children understand what is changing and why it is changing can provide a much-needed support for very difficult and uncertain transitions. Therapeutic conversations on developmentally appropriate responses to chaos and transition may be able to help both the adults and the children make meaning from painful changes. It is also important to help families develop predictable routines that are centered on the family's strengths. The development of routines can add a sense of cohesion to the family life. These routines contribute to the child's safety and to threads of continuity for children who face unpredictable environments. This practice can enhance the parent's ability to provide regular and comprehensive parenting care, and can provide stability and certainty for the children in the family. In one particular qualitative interview of children living in homes with parental co-occurring disorders, the children overwhelmingly reported that they cherished the times their families were able to spend having fun together, and wished they had more opportunities to participate in normalizing family fun activities. Encouraging families to get outside together on a regular basis can greatly reduce stress and infuse a sense of normalcy and silliness into an often serious and stressful family life. Helping professionals can assist families in identifying a variety of outings that are either free or of nominal cost. Programs should also model, encourage, and provide space for normalizing family fun activities for families involved in services. The opportunity for relaxation and fun is not likely to be commonplace, and families can benefit from seeing constructive activities modeled and participating in structured events. The unfortunate reality of parental co-occurring disorders is that emergent situations can and do arise that can put the child at risk. Parental suicidal ideation or suicide attempts, active domestic violence, drug relapse or overdose, and acute psychiatric crises are ongoing realities for these children. One of the most critical steps in working with a child of a parent with co-occurring disorder is to assist the parent and child in developing a workable safety plan for the minor in case of an emergency. The detail and specificity of the plan can be altered to match the age and developmental stage of the children involved, but the plan should ensure the safety of the children in the event of a parental emergency. It can be as simple as having emergency phone numbers posted on a wall or entered into a cell phone, and as complex as written plans detailing steps the child should take in each situation the family can brainstorm. Depending on the reliability of the child's existing external support system, adults outside of the child's immediate family may play a large role in the safety plan. Each person should know how they are included in the safety plan and what they would be expected to do upon the plan's implementation. This safety plan should be revised routinely and always take into account the developmental stage and ability of the child. Parents may also choose to work with social workers to develop legal standby guardianship or temporary guardianship for their children should the parent need to be institutionalized, attend residential treatment, or become incarcerated. Many times, parents with co-occurring disorders are so distracted by their own issues, they are unaware of their children's developmental milestones and may need assistance learning age-appropriate expectations and reactions, as well as positive disciplining skills. Videotaping of the mother-child interaction can be especially helpful for mothers who can then review and process the tape with a supportive practitioner. Many models exist for parenting interventions. The most effective parent training seems to be offered in the community where skills can be modeled, coached, and practiced in the setting where they will be used. Basic assistance with the needs for daily survival cannot be overemphasized. For many parents affected by co-occurring disorders and living below the poverty line, providing adequate food and shelter for their family is a more pressing concern than receiving treatment for addiction and mental illness. These families need help meeting their basic needs. Providing housing assistance and needed clothing and furniture has been shown to effectively reduce the risk of the child's placement in substitute care, as well as repeated child maltreatment. Assistance accessing community resources for basic needs can be invaluable to these families. As we have been learning throughout this tutorial, these children are at a greater risk than their peers for a host of developmental delays and psychosocial complications. To ensure that they are receiving adequate support, they need regular biopsychosocial developmental assessments and subsequent referrals to any additional services. The National Abandoned Infants Assistance Resource Center at the University of California at Berkeley convened a group of professional experts between 2011 and 2014 to document the potential impact of a parent's co-occurring mental illness and substance use on a child's safety, development, and well-being, and identify and/or develop effective interventions to promote the safety and well-being of infants and young children whose parents suffer from co-occurring disorder. In considering the issues, this committee delineated the following characteristics of a truly integrated service system for families affected by co-occurring disorder. A truly integrated service system for families experiencing co-occurring disorder should address the whole, not the sum of the parts, reflect a strong family-driven focus, ensure access to services via any entry point, require programs to collaborate and communicate, offer transdisciplinary staffing, develop and utilize cross-training materials, demonstrate awareness of multicultural needs, identify children's needs at each step, develop trusting relationships with families, and require a partnership with the family. The same committee also developed a set of overarching principles that affirm the rights of children from families with co-occurring disorder and provide a shared vision for an integrated system of needed interventions for kids. These include: children have a right to reach their true potential through the promotion of their dignity and self-worth. Children deserve safe, stable, nurturing relationships. Children deserve the right to heal with their family. Children have a right to have their needs and voices heard with compassion and respect. Children have a right to developmentally and culturally appropriate education and information about parental substance use and mental illness. Children's issues, concerns, and needs should be included in their parents' service plans. Children should be connected to community and natural, informal supports. There are additional resources available for clinicians who desire to learn more about assisting families affected by co-occurring mental illness and substance use. With support from the Federal Children's Bureau, the National Center on Substance Abuse and Child Welfare has developed a toolkit to help child welfare workers support families affected by parental substance use and/or mental illness. The toolkit is intended to provide learning opportunities and baseline knowledge on substance abuse and mental health problems and interventions, motivate and facilitate cross-systems work, and incorporate cultural awareness and facilitate cultural competency in child welfare practice. The free toolkit can be accessed on the National Center's website. With support from the Federal Substance Abuse and Mental Health Services Administration, 0 to 3 developed a community action guide that uses a case study approach in presenting resources that service providers, advocates, and practitioners can use to engage the community in responding to children whose caregivers are negatively impacted by mental illness, substance abuse, and trauma. That free guide can be found at SAMHSA's online store. Family and Community Services of New South Wales, Australia, has created books specifically for children whose parents are affected by mental illness and substance use. These books can be effective tools to introduce the concept of co-occurring disorders to children, normalize their experiences, and encourage positive coping skills and help-seeking behaviors. The National AIA Resource Center developed a research-to-practice brief on supporting children of parents affected by parental co-occurring disorders. This brief translates the academic research directly into best practices in the field. The services that children of parents with co-occurring disorders access are often scattered, disjointed, and have many gaps depending on needs, location, age, and ability to pay. For the web of social services involved with these families to truly coalesce to serve the children, the community must work together to coordinate services, referrals, and assessments. By adopting a continuum of care for children affected by parental co-occurring disorders, no single agency needs to assume responsibility for the full array of services. Instead, system-wide collaboration can occur to ensure that interventions are available and accessible at each stage of the child's development. Operating in a vacuum is no longer sufficient. Supporting these children requires an understanding of the complexity of their strengths and needs, as well as a firm commitment to partner with local agencies and resources to fill in the gaps. The needs of the family affected by parental co-occurring disorders transcend neatly defined departments, disciplines, and organizational scopes. They demand the development of new partnerships, informal support networks, and a commitment to connecting systems that are not typically aligned.